think it's because I muted him. Okay, I'm gonna say something again.
Hello, 23 lessons for teaching critical thinking.
I'm here. It's good.
So you figure out how to get this kind of. If you ask For example, in my memory disorder, I get medical students for an hour at a time, and then I never see them again. Usually, I would say unfortunately, but I don't see them. So the question is, what do I need to teach them? And I feel I don't have to teach them their trocranial nerve and the eighth nerve is and so on. That they can learn for themselves, or they should have learned for themselves. So I'm interested in what can I teach them that they haven't learned, or they won't learn, or maybe they're unlikely to learn. And I say this is related to critical thinking. Next slide. Next. So if my 50-year-old patient wants to know what they can do to age well, let's say they have a familial risk of Alzheimer's. If I had 100 hours available to tell them what I would like her to know, that would be in my book on aging. But this is another thought experiment. It's a 30-year medical student coming to my clinic, and I have talked to him for one day. What would I do? Or for years, as a neurology chair, I gave a 1-hour lecture on introduction to neurology. And it was a very difficult question. What is it I'm going to talk about for 1 hour? I have 1 hour. What are my differential diagnosis of tinnitus? There's so many things you could do, but I wanted to teach them something that they might not learn if I don't do it. So I'm working on the second book, which I've called 125 Lessons in Critical Thinking, Young Doc. And I don't have time here, of course, 125 lessons, but just a few, maybe 23, as an example of what I would like to be teaching and what I am trying to teach at the moment. Critical thinking is defined as a rigorous type of thinking that makes fair and careful judgments based on evidence. And the goal of the whole process here is to be aware of thinking. I'm afraid most of us, especially younger people, just allow thought to happen without any consideration. How they're thinking, how they're making judgments, how they're perceiving, what they're paying attention to. And the goal is not necessarily to think in the right way and don't think in the wrong way, just to be aware of how you're thinking and what's influencing conclusions, perceptions, and judgments. Next slide. So my first lesson is rather obvious in a way, but then not really, because it's not something that we do all the time. So let's say we have a 74-year-old alcoholic hypertensive man who smokes, who has a stroke. If you ask a neurology resident, or who knows, any physician, why did he have a stroke? He'd say, well, it was a thrombosis, and there was a blood clot. He had blood clot. But what if I said, this guy's 78-year-old older brother was also alcoholic, was also hypertensive and smoked, and he never had a stroke? That little thought experiment shows that it's wrong to say that the risk factors were positive. I mean, riding a motorcycle is a risk factor for head injury. If you fall off your motorcycle and hit the ground with your head, that's the call. The responsible factors are more complicated. But it is wrong to associate the risk factors with the cause. The better answer would be, we don't know why he had a left hemisphere artery. And the question I would ask, if you're going to think about it deeply, is why did it affect his left and not his right, those three arteries? I'm not aware of any theory about this. And I think it's likely the microbiota are involved because, as we know, there are a lot of bacteria in the mouth, and the mouth, larynx, and ears and sinuses, of course, are very close to the blood vessels. And we know that there's an association of oral bacteria with stroke. With my colleagues in Osaka, we have just published a fourth paper. This one is in European Neurology last 2 weeks ago, showing the relationship between oral bacteria and hemorrhagic stroke. Another question is, why does ALS begin with foot weakness in some patients and some get sort of in other various onsets of ALS? And as far as I know, there's no theory about this other than the fact that it's a random, horrible, very tragic, but it's a random thing how it's done. So you won't be surprised to know I have a theory that it's because where the exposure takes place. So if the interaction between the nervous system and the bacteria occur in the colon, it might go first to the spinal cord, causing foot weakness. It happens through the nose, through the olfactory receptors in the nose. It go directly to the brainstem, or from the mouth to the brainstem, or from the olfactory receptors to the medial temporal lobe to the brainstem, looking bulbar. And I proposed this mechanism in this paper, and again, a reason I like this is there's no other explanation that I've heard of, other than the fact that it's just a random, unfortunate event. And with my colleague Zimple Korolawa, who is my postdoctoral fellow, we have a paper being reviewed painfully in scientific reports showing that gut bacteria influence ALS in G93A transgenic SOD model mice. And then let's say we have a 73-year-old woman who has Alzheimer's, who has 2 E4 alleles, apolipoprotein E4, that increases her risk 10 times. If you would ask probably any knowledgeable neurologist, he'd say, he or she would say, oh, this person has Alzheimer's because of these 2 genes. However, at age 80, 40% of people who have 2E4 are not dementia. So we know that you don't have to have that gene to get Alzheimer's. You can have that gene and not. So that this shows this is not the cause. Because of that, there has to be something else which is involved. And unfortunately, if you ask a whole bunch of Alzheimer's specialists, they all probably say, oh, it must be some other gene. Because we have this inappropriate and improper bias in favor of genes, which are not responsible for everything. That was lesson number 2. Just get the number. That was number 1. Number 2. What determines what we perceive? So William James famously said that if you leave a pack of wolves in the British Museum for 1 year, they wouldn't learn anything about art. And they'd make a big mess. But they would experience the art. But the difference is they're incapable of paying attention to what they are. So our experience does not define our existence, it's our attention. So the basic summary, at least in medicine here, is we focus on the patient or the biomarker. This is rather sad, disturbing story, and maybe it's too early in the morning to have such a disturbing story, but Janet Woodcock, who was the head of the FDA, she said when she approved aducanumab for Alzheimer's treatment, even though it didn't help the patient. It did relieve the amyloid burden in the brain, but it didn't help the behavioral cognition of the patient. And she approved it, or the FDA approved it under her direction. And she said, fundamentally, we have to stop thinking empirical evaluation is the only way of evaluating truth. And I looked up the word empirical, it means evidence. She's saying, well, we should not look for evidence all the time. We're looking for evidence too much. We should rely more on theory. I thought this was finished with Plato when Aristotle said, you want to know how many teeth in the mouth of a horse, you should look at its mouth rather than talk of it. But she's going back and recommending the totality of that. We often have this problem in monitoring patients, so that we need to, or I want to teach context of this process for lessons. Young doctors should be aware of the biomarkers. They should be aware of the MRI and the EEG and all of that, but they shouldn't think that's the same thing. Also, in a I took this picture and I put it on the wall in my office to remind me. So it might be a little hard to see, but there's a four-headed cane and then two shoes. Each one has a 2-inch heel. So this was an 84-year-old woman who came to see me, who was obviously unstable, needing pain, and wearing high-heel shoes. So now, those are not really very high, but I would prefer she has flat shoes. She has brush contact with the ground. But it's kind of a miracle. I noticed this because it's not something I usually put in my exam, look at the shoes. But I might have, by telling her this, she said to me, oh, Dr. Friedland, I was coming to see you. I told her she's 80, she's too old, she cannot wear these kind of shoes anymore. But how many times have I seen patients who similarly were wearing the wrong shoes? I didn't notice because it's not something that I normally pay attention to. Which is why I put it on the wall in my office so I can remember. This is an example of contextual errors. This book by Weiner and Schwartz says we must recognize the relevance of the patient's life context to plan and implement care. Not enough just to give them my standard information. So I found the most commonly ignored aspect of the social history is what the patient likes to do when they're not working. So everybody knows, we all know we got to ask about education and occupation. But then what about maybe they work, they're patients and accountants. They have a CPA degree and they're an accountant, and then hobby is raising cats and they have like 20 cats in their garage. That might be something you want to know. So a patient in Japan last year who had encephalitis from salmonella from the turtle. But nobody asked him about it. Oh. Then this is to point out another lesson here is these animals all have different ways of examining the world. Dolphins can use ultrasound without any machinery. And bees can detect the electric field of flowers. They didn't know flowers had electric fields, but 6 months ago somebody found flowers electric fields, and it can be perceived by the bees, and the electrical charges help pollen to stick to the bee. And of course, echolocation at that. This shows we don't perceive the world the way it really is. That would be impossible. If I would go home from this meeting and be remembering what everybody here is wearing, it would be a big task on my cognitive processing and memory capacity, which would be similarly, a rattlesnake can perceive heat. We can't do that. We can't perceive it like a rattlesnake. So the point of that is we don't see the world the way it really is, which means we need to pay attention to how we perceive the world because of errors, and we need to know that can affect our attention. So this heron is not looking at all the colors of the different leaves because it's not important. It's looking for motion, which is the best clue to something which is. And the best way to understand this is from evolution. The way our perceptual systems have evolved is to enhance our survival, not to enhance our artistic capacity or to enhance our ability to have children, only some feet, and to have a mate. Because we don't see the world the way it really is, we need to pay attention to our perceptual processes. So, one aspect of that, I guess, is speaking for myself, I should enhance my attention to the patient and what shoes they wear. And a key aspect of this here, lesson 4, is listening. The lost art of listening and ignoring the patient as a human being is potential failure. I hope this is from Bernard Lohm, who died a year or two ago after winning the Nobel Peace Prize in 1986. He has a remarkable book, which is now maybe 20 years old, which you can buy for like $5 on Amazon News, The Lost Art of Healing. And he talks about the importance of listening to what the patient has to say. And I can admit it's not uncommon that I go to see a patient and ask, what is your relationship with the patient? And I'm his sister. The patient, you have a brother, sister. Oh. The problem was, I asked a question, and when he's giving me the answer, I'm already thinking of my next question and not listening to what. This was very well described by Osler, who was a Canadian doctor who worked at Hopkins, who wrote the most important medicine textbook in 1950. He said, he didn't actually say it this way, but I'll put it like, she who studies medicine without books sails an uncharted sea, but she who studies medicine without patients doesn't go to the sea at all. So I was a neurology resident at Mount Sinai, and my teacher, I had two chiefs. One was Bender, who was very interested in patients and paying attention. Then I was going on attending round. I was a resident. We got a new neurology attending in Columbia. And our practice was to present the cases to the attending and then see the patient and then split the case. So this attending came, we presented the patient, and before we were finished, he said, oh, there's a paper in the Green Journal that shows this. Go look it up. And then we got up and we were going to go see the patient. And he said, where are you going? So we're going to go see the patient. So I already told you what's the matter. He was happy to make his diagnosis based on what he didn't want to go. Osler said, listen to the patient. They're trying to tell you the diagnosis. So I have two examples of this. One man with right ulnar neuropathy, 25 years old. I didn't have any reason to explain why he had ulnar neuropathy. He didn't have diabetes. He wasn't alcoholic. And he didn't have a car accident. And the key thing was, I said to him after his EMG third visit, I said, did he have any idea why he had this? He said, well, maybe it's because I'm playing this video game where I broke my thumb and it was that over and over. So this was my only known journal paper, video game called 1984. I had a 35-year-old man who had a radiculopathy. I didn't have any reason why he shouldn't have. He should have that at such an early age. He hadn't had any accident or injury, and he did an EMG and an CT scan, and nothing was wrong on the CT scan. But he had this pain. So I said, did he have any reason to believe why he had this pain? He said, maybe it's this yoga posture that I've been practicing. I said, show me, and he got up on the bed, counting the table, standing on his head with his neck bent. I said, don't do it. But I wouldn't have known that if I hadn't asked him. This is, of course, it's not always this simple. But the idea is attention to the patient thing. Tell you what it is. Because the disease is common, but the patient is. And we need to listen to understand, not only listen, not only prepare what we're going to say next. Okay, for the next lesson, so this is Christopher Columbus and Post-it notes. Anybody want to say what they have in common?
Or something else.
Exactly, that's right. Thank you. They were theories are not true or false. They are fertile or sterile. This is a saying from Claude Bernard, who is the great physiologist from France, a friend of Louis Pasteur. And Columbus thought, we'll get to Asia by going west, and he was wrong. But, you know, it was like important. Post-it notes were invented in a search for better glues. And as a glue, it's a failure because it doesn't hold very well. And when they found it didn't hold very well, there was one guy there who was suited, and the company kept on telling him, get lost, it doesn't work. But he said, maybe you do. So Post-it notes are the largest product of the 3M company. And it's a failure in terms of it. So that both in research and clinical medicine, we shouldn't be worried that much about having our theories be wrong, because they could still be very valuable, even if this is rejected. I think it might be, maybe we should do a final test. Those of you are wrong, but you might have something else. So we need to be open to this idea that theories are not true or false. And Claude Bernard recognized the importance of balance, which is a key factor in aging, because homeostasis becomes more and more fragile. Get all the decline of different organs. Lesson 6. My other chairman was Mount Sinai was Melvin Yar, who I will say very little about, other than to tell the story that we went to see a 34-year-old woman who had a headache and a blood pressure. And she had an injury, and at the time there was no CT. And it showed she had a brain tumor. We went on round with the chair. So there, as you know, there's the chair and the attending and maybe 5 residents and 4 medical students were going on. We go to see this woman, and she has a chair next to her bed. She says, Dr. Yar, please have a seat. He said, no, I don't need to sit down. Thank you very much. And he puts his arm on her shoulder and says, angiogram shows you have a brain tumor. The neurosurgeon will be here in 2 hours. He starts to cry. And he leaves the room. And in the hall, he tells us to observe this pseudo-vocal affect and emotional incontinence caused by the loss of inhibition. And I still feel such, I guess, I'm angry at this guy who was unable to appreciate the emotions of another person. He had an intellectual, this is called intellectualization, where you, instead of allow emotions to develop, you find words for them. Using reason and logic to avoid uncomfortable anxiety provoking. Using thinking to avoid the boy's feelings. There's no reason to believe she had suitable before. She just was given some bad news. And the other part here is, it's a rule you must be sitting down to be given bed. And it was rude for him not to have accepted her offer. There, she knew something was going to come out of it. He wanted to have a serious conversation. He wasn't willing to have a serious conversation. Another lesson. This is the best summary of this, which is older stories or books, which is a very obvious, easy question. But it points out that we've had books for several hundred years. And until the 20th century, most people on Earth were illiterate. However, we've been telling stories for tens of thousands of years. Nobody knows exactly when language developed, but certainly tens of thousands. Imagine a clan in Norway 15,000 years ago, where they have 5 children and one of them just doesn't pay attention to his grandparents. He has a gene or complex of genes. He doesn't like stories. He just wants to play with his toes or whatever, play with the salted fish, and he doesn't pay attention. And then something bad happens, like they have a drought or a flood, and he doesn't remember what the grandparents told him about how to respond to this, and he dies. So the passing on the genes for not paying attention to stories would be lower. And unlike his siblings who hopefully were paying attention to every word that old people said. So my only point here is paying attention to stories is a function of the brain. It's part of our genetic inheritance. So when I look for a movie to watch on Netflix, I'm astounded. There are so many movies. And I won't say anything about how good or bad they look, but it's just the fact, the reason there's so many movies is people like the story. And it's part of our evolutionary inheritance because paying attention to stories is that. And what I want the students to know is that attention to the patient is a better way to learn than attention to the book. Not that we shouldn't and they shouldn't read books, but they could learn better from the patient. And if they have an opportunity to learn from the patient, they should take it. They also should read books, but it's better for learning on a human neurological evolutionary basis to learn from patients. So I'm sure you've all seen this experience where with a patient and a student, and I get the patient, I said, would you please come in? I'd like to see you walk. I take them out in the hall to walk, and the student was sitting there. And then the patient comes back and said, what did you think of the cake? And the student says, I didn't see. Well, then why didn't you? And I remember what they would have said to me if I did that. No. And we had a student last month. We discussed the case with the nurse. Then we said, okay, let's go see him. And we go, I'm going, the nurse and me and the student, and we go. And then the student, before we get to the room, he goes this way and says, I'm going to have lunch. I asked him later, what happened? Why did you come? He said, I was hungry. And I wrote a note in his record that we, neurology department, will not take him. Of course, he might not. He said he was interested in neurology, but we're not. So, but it's just astounding that if they learn something from a patient, they will remember it better than if they learn it from a book. And this is part of the way evolution has prepared the brain for appreciation of stories. And William also said this. He said every student should have a little book. I have a little book. I have bought a whole bunch of these, and I give them to not particularly this one, but having a little book means you can write things down, and when something happens, you think like, well, what is that? What is that? You can write it and you can read it. If you see a patient during the day and you read about it at night, you will remember that better than if you read it, a month later when you're studying. And the mind does not work in rational thinking is only one kind of thinking. It's not uncommon. I'm driving in the car and I'm thinking about something. I'm reading paper, listening to the radio, and that's something. Whoa, gee, that patient with proptosis has all that to do. I think of neurological, something that can occur. And if you write it down, unless you have a memory in which you remember everything at all times. And every time I see a new patient, I read it. Lesson number 8. Rare presentation of common events are more common than common presentations of rare events. This is very hard for me to explain to Japanese colleagues when I was there. So I can, of course, I could say it in English and let them translate it, and they didn't get it. But it's very important because we think about Creutzfeldt, because it's a very interesting disease. It's very uncommon. So if you had 100,000 people, you might have 5 to 10,000 of Alzheimer's and less than 1 with Creutzfeldt. So that doesn't mean, the patient could have Creutzfeldt, but we should think about the probability. And the neurologists in the room who are not actually in the room, but they would know my obsession with this idea that words influence the way we think. So if you ask me if there's an elephant in this room right now, actually any size elephant, baby, adult, I could look around, I could look under the table, and I could look in the closet. There is no elephant. I've eliminated the possibility. The chance that it's an elephant is 0. So I ruled out elephant. But we can't do this in medicine, or very rarely. So intracranial bleeding usually causes blood in the spinal fluid, but not always. So if you do a spinal tap and there's no blood, you have not ruled out intracerebral hemorrhage. You've provided evidence against the presence of it. So my fear is that the words influence thought in a very strong manner, and this is the Sapir-Whorf theory of language, which implies that words or thought is determined by words, which is probably wrong, but we know certainly the words are thought is influenced by words, and we have to pay attention to that. Language is not only a device for recording experience, but a way to define it. Another example. Next slide. Next. An example of this is just an example of how important words are. Putin has ordered this special military operation, and he doesn't want to. You can't say in Russia, apparently, you can't say it's an invasion. This is just an example of how important words are, not only in medicine and science, but in politics. This would be one of my most important lessons, but one I'm most concerned with. Why would a student not get up and see how a patient walks? I mean, I want them to be fierce. They think they're going to learn by osmosis because they're present that they will learn. So when in the old days like a year ago, 2 years ago, when I gave lectures to the medical students class, and there'd be 100 people, there'd be 30% of the class attending, and they'd all sit as far away from me as possible. And I would say, I have no infectious conditions. and have seats in the front for the same price. Why would they sit in the back? And they're all on, on an iPad as I'm talking. So I want them to be fierce, and I want them to nurture an intense or ferocious aggressiveness in the pursuit of their learning and in the pursuit of the patient's benefit. And actually, if we could give them an inoculation, immune, and do that with a shot, that would be not possible. How to do this? I don't know. I thought this could be a symbol of the kind of aggressiveness I'd like to be pursuing their own learning. So here's an example. If the medical student is in the OR and the patient has some problem and they get admitted to neurosurgery, the next day let's say they're still in the ER. I'd like them to go find out what happened to that patient and learn what happened to that patient. And if they went to the OR, I'd like them to go to the OR. I mean, of course, with the permission of neurosurgery, they probably will. But
You're always welcome.
But the chance that this happens is very close to zero. Because medical students they're just so passive, they're just observing what happens, and you want to get them to nurture an intense and ferocious aggressiveness. They go pursue their learning, learn what happened to the patient, and particularly emergency room doctors. I can't understand how they could practice and not learn what happens to their patients because they're seeing them once and then never seeing them again. And I've had times when I would give them feedback about what happened. They don't seem to be interested. How could they practice medicine without an experience? So I thought this is an example of what kind of ferocity in the benefit of the patient, so that if they read something and somebody from Thailand publishes a paper about these are the patient they have and they have a question, I want them to be fierce in the pursuit of the patient's benefit. Go write an email to that doctor from Thailand if you don't understand their paper. The worst thing that could happen is they won't answer you. Education is not the filling of a pail, but the lighting of a fire. But it's only those things which you notice the attention determines period. Lesson number 11 is the key factor. The key factor which determines what we perceive as our attention. And we need to pay attention to that. We need to, this snake, actually there are two snakes, one on the bottom and one in Japan, actually a serious poisonous snake. But again, the snake is observing what's moving, not the color or sound, particularly not the sound of having ears. Now, bias is important, and the key factor about bias is you can't avoid it. It's part of human nature. What is important is to be aware of the kind of bias you have. And this lesson involves various forms of bias, particularly how the way information is presented influences well. So if you have a student and you'd like the student to see a patient, don't tell the student what the diagnosis is. That will train the interaction. So I have a rule that I will never look at an MRI scan before I see the patient. Of course, if it's in the ER and broken, it's different depending on the situation. But if you're seeing an outpatient, you might be biased by the pathology in the MRI and not look at the patient with an open mind. Similarly, if you read an EEG, it's best to read it first without knowing why the EEG is done. Then you learn about communication and see how that might fit with what you've read. Because having preconceived ideas is a form of bias. We're all kind of biased in favor of common conditions because that is our experience. But there are some physicians I know who just like to make rare diagnoses, especially to make them look good, because they know more about things. So my chair, Dr. Yar, liked to say patients had paraneoplastic transverse myelitis because he wrote a paper about that, and he made that diagnosis every 2 months, and he was always wrong. There's also experimental bias. Rosenberg and colleagues showed that if you tell students testing intelligence of rats that this group of rats is very smart, they were bred over years to be very smart, and these group of rats are quite dumb, and you give them students to test, even though the testing is done electrically, not by hand, they'll find that the bias that the students have gets transmitted to the rest. So that double blinding is very important. And I think this could be a big factor in these Alzheimer's drug studies because they have significant side effects and patients can guess they are in the treatment group or not. And can you go back one? Right, so in the study about intracranial calcification, we had to, we were looking at the pineal gland and choroid plexus calcification or mineralization. But we would be biased by noting the cortical atrophy in Alzheimer's patients and the lack of cortical atrophy in healthy people. So in order to get rid of this bias, we had aluminum foil made so that you could only see the center of the scan. Lesson 13, look beyond the easiest options and pursue the best resources possible. Solomon Carter Fuller was a African American from Liberia who came to the United States around 1890 and trained in pathology in Boston and realized that he didn't know that much about neuropathology, so he wanted better training. He ended up going to work Alzheimer's in Germany, which at the time was one of the best labs in the world. So the idea is, I would like students to look for the best opportunities possible. Lesson 14, pay attention to the assumptions of the diagnostic testing and research evaluation. This is particularly true if you think about functional MRI. It's based on the difference between metabolism and blood flow. That metabolism increases with activity, blood flow increases more than it should. So it's not a direct measure of activity, it's a direct measure of something else. Stuart Shallop wrote this famous paper on Alzheimer's disease where he found that smoking was a risk factor because his patients were all veterans and his controls were all non-veterans. As you know, veterans are required to smoke by my former lab chief, Stanley Rappaport, did a study in Down syndrome showing that they had higher metabolic rates, higher rates of glucose metabolism. And that was why they got Alzheimer's, paper 1983. But what they didn't measure was the attenuation of the radiation from the head caused by the fact that Down syndrome head was small. We generally assume the patient's family has the best interest of the patient in mind. But that's not always the case. And the tragic example of this, and next slide. Next. This is a neurologist who was killed by cyanide poisoning in 2013. This are originally published in the manual. And she went to work. I think she was working at Penn, Philadelphia, and she got very sick. She went to the hospital, and I can't imagine if the people who saw her there in the ICU first night were considering whether she had been poisoned.
I think I have no idea.
Her husband was working the cyanide in the lab. He's a basic scientist, and he says he's not guilty, and he's in prison for life. He's undoubtedly planning some appeal, and of course, I have no idea if he did it or not. But my only point is that when we see patients in the ICU or also even in clinic, sometimes the patient, usually the family wants the best for the patient. Sometimes the family would like the old guy to drop dead already, and they want to vote on this call. It's not enough to just assume that. The idea is we only have one patient. The family is not our patient. The patient is the only one. We could consider the needs of the family, but we consider primarily the needs of the. And I think I will conclude. Lesson number 17, ask why. And this is kind of sad. But the 78-year-old man, he fell and he had a hip fracture. And what is the orthopedist going to do? He's going to fix it. He or she is going to fix it. Right. But is anybody going to ask, why did he fall? Because there are more things to be put down there. But I'm not sure how many orthopedists pay attention to this. I had an old aunt who at 93 she had a stroke, and everybody said she fell down the stairs. She had interstitial hemorrhage, and she lived a few months and died. And I went to visit her shortly, and I met her neighbor who said she was there when she fell, when she fell and hit her head. And they were standing at the top of the stairs when she suddenly jumped in the air and fell down. Why an old woman would jump in the air? She must have had a stroke, so it wasn't caused by the fall. But so that there are reasons behind these things which are important. And of course, many of these things could cause the fellow to fall again after he goes home and gets his hip repaired. Next. I would be grateful for your feedback, either through email or questions. If there's anything that you would add to the discussion about what you want students to be taught. If you only had an hour, or if you had more time than we have now, what is it they need to know that they're not going to learn from books?
Another question. So I've been thinking a little bit about teaching in the era of ChatGPT now. And I think over the last 20 years, a significant shift in how we acquire information. you can go to the library and all down and that's become very easy. When you call and you ask any question, whatever you want. Now with, AI being able to produce, summarize it, gather that information for you. That's going to be utilized hopefully in meaningful ways. What do physicians need to know now? I think critical thinking is even more important than memorization. How do you think about that?
Going to get worse. Right. So, I hope that AI is going to come in our clinic, and that there'll be a computer in every room. I mean a camera. So if the patient walks in like this, the AI will tell the doctor, to consider walking. Of course, this is trivial for us, but not for some primary doctor, community who maybe has neurology. So, but it's already a monumental problem because we have no input in electronic health records. So I remember when it started, there was a users group meeting, and I went to the first users group meeting, and I had a lot of complaints. Everybody else agreed with me. We all agreed that there were like these 10 problems. And then a month later, I said, when is the next users group meeting? And they said, oh, we're not having any. They really don't care about that. But yeah, I don't have any answer. And similarly, now that the patient is learning everything we have to say about them, they're getting the report from the MRI that the radiologist thinks it's Alzheimer's disease. Maybe I don't think so. They're going to learn that from the radiologist, and they're going to freak out at home, maybe on a Friday night, and then call me on Monday and say, oh, I don't agree with that. I didn't really want them to be told. You don't want them to know they have a brain tumor from an email. And yeah, I don't know how we can fight against. And then the information toxicity is another one. Yes, ma'am.
What I noticed, and I'm so envious of residents today that they can put something on right there in the clinic. They see a patient and they have a question, they can look it up. I mean, that's an incredibly valuable learning opportunity to be able to connect it. I had a little book, and I would have to write my questions down. And then only when I got a chance to go to the library did I look these things up. And I think it's probably better that they could look it up right then and there when it happens and, connect it. But with everything, there's upsides and downsides to it. I don't think we should ignore the upside of these that we hold this thing in our hand does much more than that computer on the Apollo 13.
Yeah, I don't think. I think this is. I agree with you. I think this is fantastic. I think even something like ChatGPT will be a positive for us.
I don't know enough about ChatGPT, but they are synthesizing for you.
Oh yeah. So it essentially gathers information from the web and it creates in whatever format you like. Write me a summary of the treatment of trigeminal neuralgia.
So now the danger is that we're going to be limited by.
I think it emphasizes the sorts of things that get covered, which is, what really is important is judgment, is insight, is compassion.
Yeah, how do you use it?
And those are things that this is not going to provide. And so these things have become easy. So we have to teach
for that part.
to we don't teach anymore, hey, this is how you go and you research subject, because that's become relatively simple.
Regarding what's wrong with it? Anybody online can, right? You're gearing up or should I?
No, I'm trying, I mean, obviously drawing our attention to the chest, but there's something peripheral probably that we need to know.
No class.
Yeah, that's what I'm saying. I see the acromion. I see the acromion, but not the clavicle.
Well, a study of like 100 radiologists, they had a patient with one clavicle and missing on the other side. 90% got it and 10% missed it. But AI would have no problem with something like that. But I'm disturbed that our radiologists are still reading the X-rays like they did 100 years ago, in my opinion, because they like this for it. And they don't have to do that. They could give them a quantitative analysis. They don't.
Gotta take this call.
Okay,
Great job, thank you very much.
thank you very much. I'd be happy for any little feedback or other. I'd have not been, tell you the 100 other like considering. Yes.
What role do you think medical school and medical education plays in kind of educating students in this way? Because a lot of times what you're saying about medical students kind of being in the ER, kind of being passive, just waiting for something to occur, maybe not necessarily actively pursuing parts of their education. I remember, I guess it's been a while now since I was in medical school, but it was like a lot of the demands of whatever you had to do in school made it difficult to take on some of the active engagement and ownership per patient. Not to say that it didn't happen and not to say that people were not, actively engaged and fierce, but what can medical institutions do to kind of foster this type of thinking?
That's a very good question. And I've had resistance. I told the neurology department we should require the residents to sit in the front row. And the people in charge of the residency seem like they have the right to sit in the back if they want. But when I was a resident, we had to sit in a certain place. I think we should be allowed to have more precise questioning and even blaming. They don't know something they should know. We're so protective of them nowadays. And, I mean, if I ask a question and nobody knows, often I ask a question and it's something I've already taught them. 10 minutes later, I ask them a question that I taught them already. Nobody wants to do it. So I didn't answer your question. Thank you very much.
Very thought provoking as usual.